and this vital strategies recommendations list. And so to start off for today, we just want to review and recap a little bit about what we did last time to remember, because that was what, how long? 3 weeks ago? Feels like just yesterday. And so we can refresh ourselves a little bit about what we did last time. So last time we really jumped in to each of the 26 different recommendations or strategies that came out of the Vital Strategies amazing work that they put together for us. And we began to start to prioritize a little bit of prevention versus the things that we really wanted to accomplish, harm reduction, prevention, treatment. We talked about crisis response. We had a robust discussion about all of the things. We had a couple of to-dos that we wanted to start working on that didn't necessarily need to be completed by today, but those to-dos to help us was really an analysis of settlement disbursements. So Vital Strategies was able to pull us up exactly what the disbursement schedule was going to be. But really just legal and our administration was going to help us really just break that down for what that looks like. So that work has started. And then funding sustainable models. What grants, state or federal funding is available for those things that we either currently get or want to go after for sustainable models, which is great. And then we had friends from APS, thank you, Member Benavides. Thank you so much from APS. We're so excited to have you all here because we are missing the youth perspective and prevention stuff that we really can work with APS on. So thank you so much. That's was a huge need for us to close this up.
Awesome. Thank you. Sorry, can't be there in person.
That's okay. Thank you for being here at all. Then we wanted to really look at the list of health data that we already have access to, either at the city, the county, or APS, because that can help us inform a little bit of, because data was a big thing. The community wants a dashboard so that we know where the money's going, also linking that to health outcomes. And then we talked about what is already planned or what we're already doing at each of our entities that are respective to the recommendations that we have in this report. Because we believe that there's already some of these things working and happening, we can maybe bolster or build some more capacity around. So that was where we left off with our to-dos from last time. So I'm going to pause there. Did I leave any important recap out for those of us that were here last time? Okay. Okay.
Are you taking public comment?
We are definitely going to be doing public comments. We have public comment in person, and we also have if folks online. There was no sign up for our subcommittee meeting for public comment. So we will just open up for public comment, but I want to real quick just pause and make sure there wasn't anything else before we do that. Okay.
Madam Chair, we can call for, if we have Patrick Madigan watching in Zoom. Patrick Madigan, if you'd like to speak, go ahead and just put your hand up and we'll bring you in. Otherwise, I think everybody is in person that would like to speak.
Wonderful.
He would. So we're going to use Patrick Madigan. It's kind of informal process there.
Please.
Oh, she's
Thank you so much for being here.
So we're going to let Patrick go ahead, Patrick.
Okay, great. Hi, and people able to see and hear me?
Yes.
Okay, fantastic. So thank you very much. I'm Patrick Madigan. I'm a vice president with Goldfinch Health. We have a program called the Billion Pill Pledge, which I think that you are familiar with. We are a upstream opioid addiction prevention company, and our goal is to stop people from becoming addicted in the first place. And the human tragedy that comes from opioid addiction and overdose deaths, and also all of the substantial government spending that comes with addiction. Just a couple of quick statistics that I'd like to share with you. All of these are from studies. They're all evidence-based. 80% of illegal narcotic users get started with a prescription opioid. That's where it starts. So I know ultimately people may end up, getting a counterfeit opioid on the street that's laced with fentanyl, and that may be ultimately the cause of their death. But the start comes from that prescription opioid in the vast majority of the cases. And where do those come from? Those come from surgery. That's the number one case. Then it's not the only place that they come from, but it's the primary method by which an opioid naive patient first becomes exposed to opioids. And either that patient, him or herself, can become addicted, or they're prescribed too many opioids. They put them in their medicine cabinet. They become diverted, where they start a new addiction or they fuel an existing addiction. And so what we're trying to do is we are trying to stop all of that harm from occurring. One of the things that um, particularly important to New Mexico is New Mexico has a very high percentage of people who are on your state Medicaid program. And there was a recent Stanford study that found that 30% of Medicaid patients who were opioid naive, after they got their first prescription, became opioid dependent. So just think about that for a minute. 30% of people who are on Medicaid became dependent after their first opioid prescription. So, our program has been in existence in the state of Iowa. We're in Tennessee, we're in South Carolina, and we just started in Nebraska. So we're not a theoretical concept at this point. And I believe that Charles Goodmacher, who we're working with, has shared a flyer with you that shows that. Thank you, Counselor. That shows the results of our program. These are real world results. This is after 2 years in Iowa, and we've had a 60% reduction in the number of opioid pills prescribed after surgery, and a 92% reduction in the opioid refills, which is particularly important because certainly you can become addicted much earlier than a refill. But if you're getting that first opioid refill, you're starting to go down the wrong road. Um, One of the things too, I just want to mention is your Legislative Finance Committee in New Mexico put together a memo on the opioid settlements, and they said that the cost to New Mexico from one person having an illicit drug use addiction is $245,000. That is one person. And again, that's not my number. That's from your Legislative Finance Committee. So those are all of the costs, whether they be treatment costs, law enforcement, corrections, loss of productivity, ultimately, unfortunately, loss of life, et cetera. $245,000 to the state of New Mexico for every person who has a drug addiction. And so our purpose and why we are here humbly asking for your support is to prevent that, to stop it before it happens, to stop the tragedy of opioid addiction, overdose deaths, and in the proverbial win-win, also save a tremendous amount of taxpayer dollars. So thank you very much for the opportunity to address the committee, and I thank you for your work and your process. I just have to say, I interact with governments all across the country, and the work that this committee and that you are all doing together is really commendable, and it's noted, and we appreciate it. Thank you very much.
Thank you. Thank you so much. All right, we'll go to public commenters in the room.
Yeah,
Or we have another one online,
I
sorry.
think we have Janice Herrera.
Oh, perfect.
Hey, Janice, good evening. Would you like to speak? Go ahead and put your hand up if you do. Okay, Janice, go ahead. Thank you.
Hi, can you hear me?
Yes, we can hear you.
Okay, excellent. There are four main points that I wanted to talk about in regards to the opioid settlement funds. My first point, which I've raised in other forums, is the need for there to be some kind of transparency and accountability dashboard. My understanding from the Vital Strategies report is that, you know, millions of these dollars have already been spent. And so having some visible place where the members of the public can go and see how much is expected to be received, how much has been received, what has been spent on so far, and also tools to evaluate service providers who are currently receiving funds are all really important things that have been asked for by community members in multiple forums. So I wanted to just raise that. For my own personal experience, I have lost a loved one in 2024 to acute toxicity from multiple effects of polysubstance use, including opiates. And my friend was on a wait list for a 90-day treatment center when they died. My friend had been to several 30-day inpatient rehabilitation centers. The 30-day model does not work for everyone. Some people will require longer duration of treatment. And so I just wanted to also elevate making other options available that are longer term. I did see in the Vital Strategies report of recommendations what I would term a safe consumption site as one of the recommendations. This came up a lot in conversations with people who have lived experience with opiates. We need to save lives by offering a place where people can go to safely consume their substances under medical supervision, and where we're offering them the opportunity for intervention so that when people of their own decision-making process decide they're ready for treatment, that right there on the spot that they can get referral to active treatment and services. And then finally, my fourth point is that when we did the health assessment around opioid needs for Bernalillo County, this was prior to xylazine hitting the scene in Albuquerque, and I wanted to emphasize that part of harm reduction services, part of a drop-in treatment site should include wound care. With xylazine and the lesions that it causes, wound care is going to be an emergent and ongoing issue. And so please make those supplies available to service providers, first responders, and other folks that are likely to encounter folks where they're at. And that's what I've got. Thank you very much.
Thank you.
Thanks. And I don't know everybody in the room, but I know most, I think. Are you with the group or?
I'm with Albuquerque Public Schools.
Oh, cool. Okay. So we'll go with Eusebio. Go ahead and sit here.
Oh.
And I'll be recorded. Good evening. I attended the last meeting remotely. And if I understood it correctly, one of the primary missions of this subcommittee, your commitment was to prevent overdoses. And if I remember correctly, that was stated as such. Then at the same time, the overdose prevention centers would then sort of take that possibility, that discussion was sort of just placed to the side and perhaps not taken quite seriously enough as far as I'm concerned. So overdose prevention center, safe use site, as Janice mentioned now, it could also be branched out even further so that there's also xylazine wound care. There's other outreach, so it can be a hub both for preventing overdoses, perhaps redirecting folks when they're ready, and then doing urgent triage as necessary. So if this committee has got a commitment to prevent overdoses, I don't see how you can then say, well, perhaps this is a more uncomfortable discussion, perhaps put it to the side. Perhaps now is the time to then have that uncomfortable discussion of this is a method to help prevent overdoses. It's been proven. It's not just pie in the sky stuff. So then perhaps really seriously consider it and then put it on the list of priorities or otherwise change the mission. Thank you.
Anami Das.
Hi, everybody. So a couple things. I'm the director of HR Share. If y'all go to hrshare.org, there's a bunch of information about safe use, safer use. All of it's backed by lived experience, and it hasn't been approved by the DOH, but I have been trained by the DOH, and so have all of the authors on that website. A couple of things. There was a comment earlier about like reducing prescriptions. I suggest not messing with people's medical care. There are 92-year-old women who have fallen over that I know personally. They fall and they're unable to move until they get fentanyl in their system. This is medication for some people and for some situations. And I don't want the government interrupting medical care. With overdose prevention centers, I understand the hesitation. The idea of a county or city or state-run place where people go and treat their dependency the way they have to under medical supervision, it could be scary. What's more scary is what we have now, where we go without that, and people who use drugs only go to trap houses or only go to drug dealers' houses. They aren't able to access resources there. They're only able to access other people who are using drugs. Sometimes we keep each other safe, but other times we're doing other things that maybe the government shouldn't be like interested in continuing. What's the other thing? The idea of harm reduction being a tertiary form of prevention. That's true if the goal is to prevent drug use. If the goal is to save lives, harm reduction is primary. And I think our goal should be to save lives. This money came to us because people died. We all know at least one person who's died. Harm reduction could have helped them, and it can help the people who are suffering now. Help the people who our systems are failing now. I think it's great that kids don't do drugs, and we should put some money toward that. I also want to keep the people who are using drugs alive. Another thing. Imagine the entire city is drowning, and y'all are putting money toward trying to make the rain stop happening. Let's build a dam instead. Thanks, y'all.
And I don't know everybody's names, but Ashley is coming next.
Hello. My name is Ashley Charzik. I'm the executive director for New Mexico Harm Reduction Collaborative. I think I know a lot of people at this table already. New Mexico Harm Reduction Collaborative is New Mexico's biggest provider of harm reduction services. We provide services to around 1,000 people per month, give or take. And that can be, add several hundreds here or there, depending on if we're at an event or if we're going out of town to, other regions of New Mexico to go and, do trainings or talk to schools or what have you. One thing that I have been or had the privilege of seeing in my career is a safe consumption site or an overdose prevention site. I was actually able to visit the overdose prevention site that exists in New York. I just have to say that, and also knowing their director personally, seeing a safe place where people who use drugs can come to get treatment, they come to get needs met, like nutritional needs, housing needs, medical needs, psychiatric needs. It allows for there literally to be a hub that centers around people who use drugs having the opportunity to not just live another day. It's not just about surviving. It's about being able to thrive and move on to whatever's next in life for that person. Whether that means discontinuing drugs or not isn't necessarily the focus. The focus is that this person can actively engage with society and live in a way that they're not harming themselves. They're not at as high a risk for overdose. And actually, most people, if you look at statistics nationally, do go on to recover. A lot of us just do recover. But the other part of this is that a lot of us do die. But what makes it risky for us is being out in the streets, being in a place where we don't have the support to continue, reversing overdoses. People who use drugs are the front lines of the opioid epidemic, hands down. People who use drugs are the ones out there reversing overdoses way more than somebody like myself who's out there doing outreach and boots on the ground every day. That being said, with this community of people who uses drugs, they're also at a loss where they don't have the things they need. Something like an overdose prevention site, which my organization is willing, the day that legislation goes onto paper, to literally switch all of our intent, money, everything. Even like our building is set up to when the day that happens, we are switching to becoming an OPC immediately. So as somebody that can say that honestly, I just want to let you know that I want to give people that opportunity. You also have the ability to give people that opportunity to know what it's like to come to a safe place and be able to move forward in life while having that support and losing less of our friends. And when I walked in the room and heard the information about, we need to take away people's pain medication. Taking away safe supply, pharmaceutical supply, is not the answer. The supply that we need to be worried about is the illicit supply. And every time that we continue to criminalize and drug bust and we take supply off the streets, that's how we get the more dangerous supply. Xylazine came here when our amount of drug busts went way up back in May. And also, there was a huge drug bust that happened that was on one of the national, lines, basically, or a federal bust happened. But all of that being said, we know the law of prohibition. We know that newer, dangerous, more terrible things are coming every time we pull safe supply from the streets. Don't worry about the people getting their medication. Though that study from Stanford, there are studies refuting it. Please go and do the research. I beg of you to do that. But just know that the safe supply is not what we need to be looking at. It's the illicit. Thank you so much.
Thank you.
Thanks.
Hello. My name is Dr. Mario Leyva. I'm a general surgeon here in Albuquerque. I've been here for 15 years. I'm the chief of surgery at Lovelace, the robotics director as well. And I've been kind of passionate about narcotic prevention from the medical side for quite a long time. I've actually gone to Capitol Hill and spoken with a couple of the representatives there on Voices for Non-Opioid Choices. And I live it every day. I see it every day. I see how narcotics began in certain stages, not all the time, but they began after a surgery, they get some narcotics, and that leads to a large percentage of time to other things, especially with refills of pain medications and so forth. And it's a complex issue. And I hear everybody's voice, and I understand there's not a solution, but I really think that if you're going to break this cycle, you have to do something different than is being done, and prevention is really key. Okay, preventing this whole thing from happening leads downstream multiple effects. An ounce of prevention is worth a pound of cure, right? I see it in surgery. I mean, what I do is, there's different ways to do surgery. You can do surgery, big cut, big incision. They're going to have a lot of pain, and it's normal to have pain, and it's normal to want to treat pain. However, there's different ways to do that, and New Mexico's getting hit very hard from all angles. We have doctors leaving in droves because of the medical legal system is just gone haywire. Huge settlements on different things and so forth. So we're trying to focus on taking care of patients, but education, it's a poor state, a high Medicare state. These are patients who are, you know, at risk for having problems to begin with. They're rural, they got to get, you know, medications. It's tricky. Trying to do minimally invasive surgery, small incisions, doing protocols to minimize narcotic use, multimodal therapy, different Tylenol, ibuprofen. And yes, sometimes you do need narcotics and sometimes you do need these things. But I'm telling you, I brought in medications that will negate the effects of narcotics, and the systems say, well, that's too expensive. We're not going to do that. So you're left to prescribing narcotics. So what you have to do is you have to be judicious on your narcotic, you know, how much you're going to give patients, how you're going to do the surgery, trying to take the whole picture and minimize, but also treat that patient with compassion and make sure that they're getting the adequate care. And what's been done in other places like Nebraska, Tennessee, and these South Carolina, Iowa, there's these programs that are actually focusing on encouraging the physicians, the patients, and the hospital system to get together and learn about what the problem is, how to solve the problem, because, you know, that's where the ground starts. And then, you know, that leads to other things. And, you know, I don't know a lot about the illicit drug use and so forth, but I know that's a big problem as well. And that needs you know, treatment and so forth. But if you start early and start prevention and educate everybody and use some of these monies for that with proven track records, I think that, you know, New Mexico has a chance. If you look at the stats, we're dead last a lot of times in healthcare, narcotic abuse, education, poverty. I mean, we got to change something. And you, you know, people here at the table, you have the power to start that. And, you know, I'm happy to answer any questions. I'm sure these people are also happy to answer questions. I can't say it all in this little bit of time for your sake, but there is a war going on in the ERs with people coming for pain medications. They don't have PCPs, they're getting their treatments. It's a big circle. And to break that cycle, we need to do something different, and hopefully education, prevention is the key. Thank you.
Thank you.
Any questions? Yes.
Thank you. Yeah, and I did want to take this time. I was just asking Charles that maybe you could come back next week for our big meeting, give presentation. But since we have you here,
yes,
let me just ask the questions that I would have asked next week,
sure.
or next because I met with you before,
yes.
And I just wanted. I think when we met, you were able to explain to me sort of the step by step, right? Most folks here aren't familiar with what it means to do surgery, what is, and I think when we talked, I remember you saying like, great, there was a big push. And I remember like all the Purdy Pharmacy folks coming through and pushing their pharmaceuticals up. I assume that still happens, right? But that, you know, there was almost like a training for doctors to be able to say, like, a bunch of people came in and said, hey, prescribe our medication and prescribe this medication. And what you all are proposing as Goldfinch and the folks that are doing are to say, let's educate the doctors on alternatives, on, like you talked about, Tylenol and ibuprofen over, and how to measure sort of when you do need to give opiates or narcotics, how to measure what the need is. And I think that and so I guess I wanted you to say a little bit about that.
Yeah, sure. Thank you. So surgery is sometimes necessary, right? We all have to get surgery, and it's painful and it's scary. And patients, the first question is asked, is it going to be painful? And yes, you're going to have surgery. It's going to be painful. And someone that's pain naive, that's never had any narcotics, you know, one pill is probably knock him out, but someone that's had, you know, multiple, so everyone's a little different. You have to take an individualized approach. Well, what happens is, if, you know, the way I was trained in residency was, you know, person taught me, was like, hey, just give 40 tablets because you won't get any phone calls. That's what we were trying. And because patients, that this was, you know, 15, 20 years ago, okay, it's not appropriate to do that anymore because we know all the downside effects. However, trying to do minimally invasive surgery, small incisions, surgery, multimodal therapy. What I mean by that is treat pain different ways. Some pain medications work here, some work here, some work here, some work here. Tylenol, ibuprofen, ice works great. It's cheap. Narcotics do have a role at sometimes. There's other, you know, 4 or 5 different things. There's also injectables that can take away the pain and last for 3 days. Of course, these all cost money, and some of them are cheap and some of them are not. So you try to take all of that and you make a program, and that program has been done. It's actually 15, 20 years now. It's called the ERAS protocols. And ERAS protocols have been well known and documented that they minimize narcotic usage and also improve outcomes in terms of leaving the hospital sooner, lots of things. And it's just that even though I was one of the first ones that started an ERAS program here in New Mexico at Lovelace, a lot of people still don't do it. And the reason they don't do it is, well, this is the way I've always done it. I always give 40. I don't get bothered. You know, we have to be better than that. So I think bringing the surgeons, the doctors, the nurses, the nurse practitioners, the PAs, everybody that's treating patients, and also the patients, right? Educate them as well. And that's what Goldfinch does, educate the patients, gives them power to say, you should be able to ask for these things. You should be able to ask for these types of surgeries. You should be able to ask for, you know, other alternatives. Okay. And if you need narcotics, you should be able to get that because, you know, you have to treat pain and you have to treat pain individualized. And then, you know, bring in the hospital systems and the community like we're trying to do. I think that's the only way to do it. I mean, taking just this part and try to make them better and not dealing with the rest of it, it's doomed to fail and it's going to be hard to push the envelope. And we may not be able to make like huge strides right away. However, if you just start with one patient that doesn't get addicted, that doesn't lead to other things, that's a start somewhere. And I think that's where I would, you know, go in and be that preventive mindset.
And just thank you, Madam Chair. Just to summarize, yes. We're saying train doctors, empower doctors with more knowledge and information about best up to date and alternative practices to the regular status quo, give them 40, and also support patients in sort of what they have the
everyone
right.
in the arena, the doctors, the patients, and also just we're training and we're trying to help. And then from there, the doctors and the patients can then be an advocate, you know, talking to their hospital administrators and talking to the people and the paramedics and the it's a wild kind of grassroots kind of spread by individual word to word, and hopefully one day it's mainstream. Like, okay, yeah, we know narcotics are bad. Sometimes you need them. How can we minimize this? And then let's take care of this problem and get New Mexico a little bit better, and in the stats and help our people. I mean, I'm born and raised here. I'm trying to help our people.
Great, thank you so much.
Yes, sir.
Quick question: are you working with academia about changing curriculum and doctor training at the beginning level?
Yeah, well, that's so. I've not worked with the University of New Mexico. That's where I did my medical school. Mm-hmm. But in my community where I operate, I've done a lot. I brought in the narcotic. I've been doing some education. I've been trying to do different things. And I'm a busy surgeon. I got busy stuff, that I'm running, like everybody is. So I definitely can do more. And this is why I'm trying to, come here, take time on my, schedule to tell you the importance of what's happening on the front line for medical side and how I see it going and how can we improve it. But, education of the medical students. My son just applied to the BAMD program, which is the high school, come out of high school, go to medical school program. And, in that, he's got a high school project that he's doing where we're giving these vials of kind of disposal vials for anyone that has surgery. After you're done with your surgery, you can throw it, your pills, any pills actually, and dissolves it, and you can throw it in the trash can and it's done. That way, when grandma has surgery, Timmy doesn't get into your cabinet and say, hey, what's this? Let's try this. So yeah, trying to start young, but also the people that, us here that have surgery and everyone else, it's a complex and you just got to try somewhere. You got to start moving forward at least a little bit.
Right.
Thank you so much.
I apologize. I did reach out after our discussion last time. DOH epidemiology report. That is a downward trend on prescription opioid overdose for the last several years. So that's good news. Mm-hmm. And I could make that report available to the group if you like.
That's great. Good. Thank you so
You're
much
welcome.
for being here. Appreciate you.
And I will try to make next meeting. I hopefully can make it.
You're coming from Santa Fe, right? Or
no, I'm here in Albuquerque.
Okay.
Just that it depends on the time.
Yeah.
We'll try.
Madam Chair, I had a question on what you just said just before we move on.
Mm-hmm.
So you said the prescription opioid overdose is on a downward trend.
Yes.
But that does that follow through to other illicit opioids that prescription may
fentanyl's
induce?
Like this, going up like this. Methamphetamine's going up like this. But prescription opioids, how they track that is a downward trend. And it's been going downward for a few years now, 3 or 4 years.
Yeah, and I think that is because of the work that's being done. And I mentioned this last time at our last meeting about my time at UNM Hospital and training nurses on teach back. And that this is not about, not letting people have what they need, but it's about teaching them about what it means when you need those pills, how to know that in your own body, when you need them, when you don't need them, how you should feel, how you shouldn't feel, how to properly dispose of them when you are done and you didn't use them all. I even have a story of a patient and a nurse was talking while I was teaching this teach back to a nurse and a patient. And the patient said, well, I thought I was supposed to take them all, like my antibiotics. So I don't have any pain anymore, but I thought I had to do it just that simple education of you don't have to take them all if you don't want to. Here's how you adequately dispose of them, which the Goldfinch kit has that. It's really just about educating folks so they know they are empowered to say, I don't want that. I would like something else inpatient when they're getting care, inpatient in the ER, in an ambulance. And I'll say it again, I was an admin assistant in the ER, and 6 years ago in the hospital, we were talking about changing our medication in the ER from oxycodone and some of the others to fentanyl. And I said to them, why are we making this switch? Like what? Oh, well, because the war on opioids. And I said, but fentanyl is an opioid. Like what? Like, so that's not the right answer. What do I put in the notes, right? Like for the notes, what's the right answer? And they're like, well, it's just cheaper. It'll help the hospital save funding. And so the doctor is correct. Whatever we are giving in the hospital a lot of times, that's the first time somebody is getting that. And then it translates to now 6 years later, it's cheaper for the hospital. It's cheaper for people out here as well. And so we do have to think about not only educating youth and educating adults, but educating the medical field and the doctors, because he's absolutely right. What we're teaching in the curriculum to that point, that's something we need to maybe put in the education. It's not just education of kids, it's education of medical providers, nurses, folks who can help do some preventative stuff in addition to the harm reduction for folks who are already in that situation. Because I think we need all of the above. All strategies need to be talked about.
So I have a question.
Please.
And it's related. Do we know how the illicit drug use breaks down? Like, do we know how many drug users who are accessing illicit drugs? Did they get them from, like, what are the sources?
Yeah, and I think that's why we spent a lot of time talking about data and like looking at those types of things. But I think for us, and I think thank you, Commissioner Olivias, for last time for really reminding us of that. Like, we have to rely on the experts to do the detailed, granular, like get into that kind of data, to talk about what strategies need to be employed once we say this is how much we want to put to each of the buckets, and here's our priorities, which is absolutely first to save lives, and then have those conversations.
But can we learn that information from the drug users? Can we learn that information? I'm thinking of high school kids because I'm an APS board member and a 30-year teacher.
Can I ask, what are you asking? Just where the sources of drugs are?
Where are people getting their drugs?
Where are they getting the drugs? Because, I mean, it could be grandma's
medicine campaign.
I think what we're saying is that it's nuanced, right? And what there's there's so many, like what you were just saying, all approaches are necessary because as many as we all have different fingerprints is all the different ways in which people are getting or not. I always say I grew up with my cousins and we were on the West Mesa partying, and for some reason they continued partying and I didn't, right? Or I continued partying when I was for fun, and they continued after work, and then when they were in pain or when they were sad, and they're still, so there's no way to like pinpoint. And what we're saying is that this is one approach where we don't have that extra, because that extra might mean, and there are grandmas that are addicted right now too, like that a woman falling might be because she needs it, because she's addicted to it. She's not out doing crimes for it, but she's still addicted to it. And then, or that grandma's pills got into her nephew's cousin's friend's hands, and those also just fueled what may already be. Sometimes it's illicit, sometimes it's from somebody's medicine cabinet. But when you're addicted, you're gonna find a way to get
your fix. Yeah.
So I guess I don't know how important the data is of where it's coming from. We know there's illicit drugs and but more that it's everywhere and people are accessing it, and how do we
but we did ask for a lot of that type of information.
Yeah, I'm just I think
because it's
putting it's good. It's just good information to get, especially from kids, because we know that's
absolutely. All right, so let's we're gonna go back to public comment, but I see Member Benavidez' hand.
Can you all hear me okay?
Yes.
Okay, thank you so much, Madam Chair and Madam Chairwoman and everybody there. Just a quick question and kind of a comment to follow up to what Board Member Dominguez said. Are you all aware of the wastewater study that was done by the Environmental Department for high schools and the drugs that were found?
Yes.
Okay, great. All right. I just wanted to highlight that and say we obviously have empirical evidence that this is happening in our schools, specifically in Albuquerque, and opioids were found. And so there's a need, and just wanted to offer that.
Thank you for that reminder. I think that's a great reminder and very, very true.
I didn't know that anybody didn't know.
Yeah. Thank you so much for that.
Yeah. Sorry about that. I should have known.
No, it's good. It's a great reminder that we know we need to focus on that for sure. And then I see Kate Bolton's hand.
Yes, thank you, Madam Chair. I'm Kate Bolton. I'm a senior legal technical advisor with the Vital Strategies Overdose Prevention Program. And I just wanted to underscore that the recommendations that Vital Strategies developed are really grounded in what's driving preventable overdose deaths now. And as you heard, opioid prescribing has been on the downswing in New Mexico as elsewhere across the country. This has been an area of emphasis for some time, reducing opioid prescribing. And, New Mexico in 2023 was not, it was not even past the top 20 of state, or it was in the lower 20 states in terms of its opioid dispensing rate. So relative to its peers in terms of overall opioid dispensing, New Mexico is not a standout in terms of what we see in terms of that level. And I would say that in many places, because of so much emphasis on limiting opioid prescribing, folks with both chronic and acute pain can sometimes not get the care that they need. And indeed, that is a scenario where we see that people are forced to seek out the unpredictable and unsafe street supply in order to manage their pain and take care of themselves. And so I just wanted to highlight where New Mexico stands in terms of overall opioid dispensing and some of the unintended consequences of a really intense focus on prescribing for pain management. And the last thing I wanted to mention was around drug disposal, and just to flag that the FDA's flush list in terms of disposal of medications includes a number of opioids. So just thought that was relevant to share. Thank you.
Thank you very much. Do we have any other public comment in the room? Please.
Hey, Brennan Ward. So I'm faculty at UNM. I'm triple boarded in emergency medicine, medical toxicology, addiction medicine, and mental health. In my job, so I'm the associate medical director of the Poison Center. I'm part of the core teaching in addiction medicine, part of core teaching in emergency medicine. Outside of that, some of my roles are I co-chair 3 different ECHOs to aim at educating physicians, with my newest one being asked by the New Mexico Supreme Court to educate judges across the state. So that's just a little bit of basics of my background. And I had a few slides that I prepared or was put together. I wasn't given a real clear direction on where to go with this. So we can either go through the slides or I can just talk. I have some slides that I put in here hidden. And so one of the topics that has been in question is, is the overprescribing that happened. I'm one who I trained in an era where we overprescribed, and I hear you exactly. Since 2010, 2012, we actually hit our peak. Is all my sources of income either are from state or public. So I got some funding from Department of Health and Human Services. The CDC, the education program, or one of the ECHOs that I co-chair, is funded by CDC, both in New Mexico, but also outside, in responding to situations where a prescriber suddenly loses their license, suddenly retires, or some of that. So those are some collaborations we have. My next slide is actually hidden that I wanted to do. But since 2010, 2012, the amount of opioid that we've been prescribing is consistently going down. We're at less than half of what we were at 2010, 2014. And yet, to Stanford's point, the drug overdose fatality has been going up dramatically. We have a little bit of hope with the 2022 data that we're starting to trend downward. To answer the question, where is this coming from? This is a talk that I put together in conjunction with a variety of law enforcement to kind of help me, give me some ideas. But the going rate of a kilogram of fentanyl is $3,000 to $4,000. So the goal here was with the $10,000 startup, because I thought, hey, that's what I could get for the shady loan place in the corner, or what I could get for an advanced paycheck. And what could I put together for a business? Get a kilo of fentanyl, get a couple of pill presses that's going to crank out 4,000 or 5,000 pieces an hour of these counterfeit pills, get a few dyes, because we want variety into, for everything from Xanax to oxycodone to whatever, have some cash reserves and other material. If we put 500 micrograms in a pill, that's 2 million pills. Prior to the pandemic, the pills were selling on the street for $20 a pill. That's $40 million. And if I go Breaking Bad style, I don't know, because we're in New Mexico, I'm still taking home $20 million on a $10,000 investment. There's nothing in medicine, there's nothing in business that's got a profit margin like this. Fast forward to where we are today, each pill is selling for $3 to $4 on the street. In bulk, they're 50 cents. Now, some of the things that I want to celebrate, I've got a 12-year-old at home who's in 7th grade. And this at 50 cents, at $2, $3, this is lunch money. And that's what has me concerned. But I also want to bring in with the APS people, you know how happy it is for a parent to come home and have your son talk to you about fentanyl addiction when he's in 7th grade? So I want to applaud APS for giving me that proud dad moment to hear this from him and to know that we've got to start younger. And we hear the studies, and I'm not shocked with the water supply, but we've got APS is making changes with that and starting to do the education younger. And now he's moving into starting puberty. So again, this is the order where we're seeing things. We've got some real forward thinkers here. So I want to applaud you for that. But when there's this much profit margin in there, you can't keep that out, the drug supply, unfortunately. I also, just as a reminder, the DSM-5 criteria of what separates out the disease of addiction versus those of us who had a glass of wine with Thanksgiving, and why I don't have an alcohol use disorder. And a lot of it breaks down into we have control. It's not me having a glass of wine at Thanksgiving doesn't interfere with my personal life, in my interpersonal relationships. It's not interfering with my work. I don't have a physiologic tolerance. I don't have a physiological craving. Part of what I'm doing from a medical standpoint is recognizing that this is the definition of addiction, and not just for opioid, but this works for gambling, this works for sex, this works for video gaming. Isn't quite an addiction yet, but we start seeing those patterns, right?
Says the video gamer.
Yeah, just because I play Flight Simulator every once in a while, that doesn't make me. But that's what separates me from somebody who does it occasionally from there. So when I'm relieving symptoms, this is what I'm targeting. This is getting into some of the biology and motivation of addiction. And this, I think, the more I understand this, the more I put here, the more it helps. So we have the positive reinforcement. This is dopamine being released in the nucleus coming to the brain. I know I get into sometimes neuroanatomy, which is not what you chose for a profession, but this is going to be brain stem things. And from a Freudian standpoint, this is the subconscious making our decisions and our motivation. So this is like, I like to call this the classic addiction pathway, where we got a couple of guys in college who they go out, they drink heavily their first night at that big party. And they're like, hey, man, that was an awesome party. We got to go do that again. And the pursuit of that party. And it's not just the alcohol, but it's the whole thing that was involved as part of that positive reinforcement. I think we know those people, and they struggled a bit in college as third year comes around, fourth year comes around, because the amount that alcohol is becoming more and more of their life. We got the negative reinforcement pathway. By the time somebody comes to me in the addiction clinic, they're all operating under the negative reinforcement pathway, feeling anxiety, fear, distress. I'm hearing the other people from public comment. I'm seeing and feeling their anxiety and the uncomfortableness, and to speak. This is all coming from the amygdala. I like to use this as like a tobacco type thing, or a nicotine. Like, who feels like a high or amazing when they smoke a cigarette or a vape? The answer is, if I don't, I feel like crap. And it's satisfying and craving. The other, example that I've seen time and time again is when there's a stressful, a bad situation in somebody's life. This is like somebody who is celebrating their 25th wedding anniversary, and their husband or spouse suddenly dies from an unexpected medical condition. And going back, living in the home, living with that void of coming home from work, and this is what's here. Alcohol can fill that. Another opioid can fill that. And part of medical treatment is getting at the underlying issue that's coming on. This slide I like because it highlights that the chronic heroin use, this was used in heroin, is the amount of pleasure that they're getting in life through dopamine is a lot less than what a normal healthy person is. Conversely, somebody who's got the amount of anxiety, fear, distress is a lot higher in somebody with substance use disorder. This is also what I recognize as an addictionologist. When somebody comes to me, is they're fearful, they're not upbeat, they're not happy. It's not always the person I want to keep in my close friend group, but I understand that there's brain chemistry that's actually going on here. This is the American Society of Addiction Medicine's 6 dimensions of care. And I'm first an ER doctor, and it's my ABCs or CAB or CAB. That's my resuscitation. These are the 6 paradigms that I work at. And I think one of the things when we start highlighting the many things that we as a state are leading the nation on really fall into here. And the calls that I get from friends, family is, I've got a loved one who has a bad meth and fentanyl problem, and I want to get them into care. And my first question is, are they ready to go into care? And start making that move. And I think with what we're trying to build with the Gateway program, what we're trying to build with the CARES campus, what we're trying to build with Albuquerque Fire Rescue is be able to meet people when they're ready, not necessarily when their family's ready, but when that person's there, and then start getting those warm handoffs onto, we're ready for an inpatient program. We're going to start you on a medication and an outpatient until we get out of a bed that's open. Start helping get them off the streets with that. Also, one of the dealing with their underlying medical problem. So if it's something that we can handle surgically to help with their, I'm going to pick on back pain because it's there. But if we can do a single surgery and help their back pain, great. If it doesn't work, then we need to start looking at other avenues. And that's a lot of what we're doing with the teaching of the ECHOs. UNM, the School of Medicine has changed a lot of their curriculum to update that. The other that is really a challenge is going to be maintaining the environment. If I have a pregnant woman who is a smoker or a vapor and they quit, great, I applaud them. But if they go home and their spouse is still smoking or vaping, what's the likelihood that they are successful in doing? Let me ask you this: what's the most successful drug treatment program in the history that's been ever documented in medical science?
Prison.
Yes. No, it was actually run by the United States Army. And this is some of Lee Robbins' original work. And what she described, among many things, is 25 to 30% of U.S. service personnel were testing positive for opioid during the Vietnam War. Simply removing them from Vietnam, bringing them back home, they had a continued reuse rate and development of addiction of 1%. I think our numbers are almost a little bit too low to believe, but nevertheless, it's the changing in the environment. Here we've got people who are New Mexicans, Albuquerqueans, and to send them back home to their loved ones, their families who are still using, I think creates a problem. So when we start needing to address homelessness, we start needing to address how do we transition somebody out from a 60-day, a 30-day inpatient treatment, a 90-day, how do we set them up for success? There needs to be oftentimes a lot of mentoring. One thing my child adolescent psychiatrists who are also boarded in addiction always say is that there's a brain development and maturity that stops about the same time they start using. So I have to, like as a physician, I have to slow down and remind myself that this 45-year-old individual in front of me is making decisions at a 15-year-old level. So that's something else that we look at. As far as
I have a question.
Yeah.
What is the role of culture in these approaches? Because I'm just thinking for Native American culture, ceremony is important. And also I heard on a Saturday local, not NPR, but public radio from UNM, a speaker who Native American, and I don't know if he was a psychiatrist, but very much engaged in drug addiction, but taking into account the role of ceremony for Hispanics or curanderismo. We have other cultures, which I'm sure have this.
Yeah,
I think it's
getting them ready. That's what
I think it's an outstanding point. And I identify myself as a Christian. My Native American population, I encourage them to speak with their medicine person and to connect with their culture. I think the bigger issue is the spirituality. I think is a big part of here, and helping somebody improve.
Yeah. Just in the interest of time. No, that's okay. I just want to just continue so we can, in the interest of time, because we're already at 6 o'clock. I think
I can be done.
I think you go ahead.
Yes, please.
I'm just putting on here in my teaching. This is just SAMHSA laying out the benefits of medication for opioid use disorder. Having spoken to hundreds of physicians, this is always when I challenge physicians to, you give me any treatment that you do in medicine that has as broad of outcomes as this. The next slide is going to be mortality. Basically, this is from the PCSS course, which was the old X waiver, which in 2024, because there is no longer the X waiver, now for people like us to be able to renew our DEA license, we're required to do 8 hours of addiction training. But with MOUD, or medication for opioid use disorder, demonstrating an 80% survival benefit, like any other modality, again, challenge question for physicians in the room is, what other treatment do we have where we have an 80% survival? Things like insulin for diabetes probably is up there, but nobody's ever done the study because it's not ethical to do that. Starting antibiotics for sepsis, for pneumonia. Some of the other work that I'm doing is, so through the Poison Center here in New Mexico, we've given free addiction advice and reached out to primarily physicians. With the want to thank Senator Heinrich, Senator Lujan for help, but especially Senator Heinrich is putting money into the federal budget to try to expand this and be an addiction help hotline to be statewide, not just Albuquerque. We've got the New Mexico Bridge program, where we're going to a variety of different hospitals across the state and working with them. What I don't see is we have worked with Loveless Women's Hospital too. I don't think Loveless, Maine. But again, trying to go and to help create the order sets that the hospitals need, train the nurses, and training the nurse as a nurse. I went to nursing school before I went to medical school. Is so important because of the amount of time the nurses are at the bedside. So those are some of the resources.
Training them on what? You're saying on all of this that you've talked about.
Yeah.
Okay.
Yeah, and addiction and the care, also, and then in proper pain too. So those are my slides and questions. Sorry.
No, that's great.
Maybe a little long.
I have a quick question, and we'll open it up for other questions. Just in your professional opinion, especially in the ER, talk to us a little bit about the safe consumption sites and what your expertise around that.
Sure. So my expertise, I've been a consultant for the Canadian government, as well as the Royal Canadian Mounted Police, and through that, while that wasn't my direct role, I have had the opportunity to tour supervised consumption facilities a few different times. Looking at the medical literature, most of the studies demonstrate a benefit in terms of improving transition from patients who are on the street and using it into care. I have yet to see a study that documents improved survival, but that's always really difficult to study in this population because how do you go identify 100, 500 people who are actively using and then follow them to do they do it? So it's a study design thing. In my professional opinion, I think it's the next step for a needle exchange program. It's the same arguments why a needle exchange program doesn't work or used for why a supervised consumption facility doesn't work. I think the problem is a lot of people who are using don't feel comfortable walking into a hospital. The first person among that they see has a badge on, and that's oftentimes triggering. Having physicians, before I got more involved in the addiction work and training in the ER, I remember it was kind of high-fiving people. Hey, we got somebody who's farming out pills, and we caught them. And it was as opposed to, hey, it's time to begin treatment. And my patients, the amount of procedures that I've done at UNM's ASAP clinic is I shouldn't be doing that in a clinic, but they're just uncomfortable going to the ER. And I think realizing the traumatic experiences. One of my pharmacists who had 30 years with us at the New Mexico Poison Center came home from dinner one night to a home invasion, got shot. As 30 years, when he was going back to the hospital to have his colostomy taken down, he was very anxious and uncomfortable going into a hospital. That's a pharmacist with 30 years of experience to his same hospital employed him. What does the average person on the street do? So we have to understand, and our vulnerable patient population is most likely to have that.
Thank you.
Madam Chair. So you touched on environmentals, and when I first moved here, I worked in emergency department, and I would talk to people about getting into treatment. And one of the reasons they wouldn't is, why would I go to a 30-day treatment? I got to go home, and my father, my grandfather, my uncle, my brother, my son are all shooting dope in the same living room. And that's a valid reason, I have to go back to the same environment. Can you talk a little bit about fentanyl and methamphetamine as far as when you stop using, how long does it take for brain chemistry? And have you witnessed or understand any programming across the country that supports that kind of length of time?
So the American Society of Addiction Medicine, and I agree with this, is we tailor it to each individual. we don't admit somebody to the hospital for pneumonia, heart disease, cancer, surgical, and say, you know, you're going to be here 1 week and then we're going to get you going. I know that happened in the 1950s, 1960s, but that was before I got into medicine, and that doesn't happen anymore. The addiction, we're also needing to tailor to it. And I think getting to your points of culture in New Mexico, while I gave the example of having a glass of wine with Thanksgiving, a lot of families use opioids, use methamphetamine, and that's just part of the household, part of the culture of what they've done. But it's just harder to mentally understand that that's just like having a glass of wine in a lot of families. So getting them out is difficult. Oftentimes they know they have to give up their peer group, and they oftentimes have to walk away or distance themselves from family and loved ones. And that's really, really hard for our people to do. And I think that's where the environment comes in. And then we get to genetics. I mean, I've got patients who the first time I ever felt normal was the first time I used fentanyl or I used heroin. And, you know, from an addiction standpoint, I know they're going to be really hard, because how do I make them feel normal? But the point is, these are people that we're trying to help when they're ready.
Thanks. Thank you. Thank you so much for your time and expertise.
Like to make one statement.
Sure, please. And then I think we have a hand up online, but please after you.
Oh, thank you. I just wanted to make clear that I support safe use sites. But I also support all approaches necessary. And I don't think it does us much good to polarize any of our approaches, right? To say like, let's not do this, let's just only do that, or that one. I think all approaches are necessary.
Yeah.
Like safety to our advocates for safe use sites.
Thank you. All right, I think we have a hand up on the line, and I think that will conclude public comment.
Thank you, Madam Chair. Go ahead, Patrick.
Yeah, thank you so much. I just wanted to make a couple of comments because of some of the questions that were raised and some of the comments that were made, I think, about our program. Obviously, you know, as Dr. Leyba was describing, our program is actually quite complicated and there's quite a bit to it. And, you know, in this short amount of time, we're not able to fully explain it. But I wanted to make it clear that we are not a prohibition program. We are not in any way a law enforcement program. We are not about taking away people's medicine. That is not what we're doing. We are our classic situation is an opioid naive patient undergoing surgery. That is our classic situation, and trying to keep that patient from becoming needlessly and unnecessarily addicted to opioids. There was a comment made about chronic pain patients and taking away their opioids, which may lead them to go to the street. Our program has nothing to do with chronic pain patients. That's a completely different and separate problem than people who get first dose opioid exposure through surgery. Let's talk for a minute about prescription rates. It is undoubtedly true that progress has been made both in New Mexico and in the United States on prescription rates, but the job is not done. There is still much work to be done. Just a month ago, the new CDC data on opioid prescription rates came out November 7th. The national average went down from 39.5 to 37.5 opioid prescriptions per 100 people. And I want to make sure that people understand that statistic. That is the number of prescriptions. That is not the raw number of pills. So that's a very important distinction. In New Mexico, the average is 33.7 opioid prescriptions per 100 people. That's 33rd in the country. So yeah, you are not Arkansas, which is number one. You are not Alabama. You are not Tennessee. That doesn't mean that there isn't work to be done in New Mexico. There are still too many opioids being lawfully prescribed to too many people in New Mexico. Bernalillo County, the opioid prescription rate is 46. That's 36.5% above the New Mexico statewide average. This is CDC data. So yes, progress has been made, but there are still too many opioids being prescribed to too many people, and too many people are getting addicted. And then finally, I just wanted to say something that kind of builds on, I think, a comment Commissioner Barboa just made, which is we are not in competition with anybody. We recognize that there are tremendous treatment, harm reduction, recovery needs in the community. We know that we want all of those things to be funded. We want to save every life of every person who is currently struggling with addiction. We want every person who is currently struggling with addiction to get treatment and recovery. We want all of those things to occur. We just want to prevent people from being needlessly addicted to opioids because they were exposed to them lawfully through their doctor and unnecessarily. Thank you.
Thank you so much. Okay, that will conclude public comment. Thank you all so much for coming. You're of course welcome to stay as we continue the conversation. Okay, so let's take a breath from that. Yes, I know, yes. All right, so I think just process-wise, we want to get back to the conversation of what we talked about, prioritization. First though, what's missing, I think is something that we should start with.
What's missing in the whole plan, or what's missing in the?
Oh, I think.
Madam Chair, I was going to suggest that before we get to what's missing, maybe we want the update just to sort of see what
from the experts
where things are at with regards to those items that we had asked to get some more information
on the to-dos.
Yes.
Okay. Thank you for that. And then I also am reminded that we probably needed to do introductions because so public knows who's at the table. So my apologies for that. Thank you, Counselor, for reminding me of that. So we'll do that. And then I think we can thank you for that. You skipped right over that. So thank you. You will please,
sure.
Counselor.
Thank you, Madam Chair. I'll start with Councilor Renee Grout, District 9 City Councilor for Albuquerque, was here earlier and had to leave to go to a neighborhood association meeting. So that was the person sitting next to me. I'm Tammy Fiedelkorn. I'm District 7 City Councilor for City of Albuquerque.
Thank you. Councilor Nicole Rogers, District 6 here in Albuquerque.
Adrienne Badwa, Bernalillo County Commissioner for District 3.
Eric Olivas, Bernalillo County Commissioner for District 5.
Abigail Stiles, Senior Policy Analyst for Albuquerque City Council.
J.R. Rael, I'm the Executive Operations Officer for the City of Albuquerque.
Stanford Kemp, Deputy Director, Health, Housing, and Homelessness, City of Albuquerque.
Josefina Dominguez. I'm a school board member, District 6, which serves Manzano and Sandia, but I also serve all schools. So happy to be here.
Wayne Lindstrom, Deputy County Manager for Behavioral Health with Bernalillo County.
Wonderful. And Member Benavides, if you'd like to introduce.
Sure, thank you. I'm Heather Benavides, and I am APS board member for District 4, encompassing Nob Hill International District and the Southeast Heights.
Thank you so much. All right. Thank you. So to Commissioner Olivas's point, just want to do some updates on the to-dos and where we're at with the to-dos. So we'll start with the analysis of settlement disbursements. That was going to be the city's admin and legal, and I think Mr. Rael has an update on that.
Sure. So we're currently working with our legal department, and right now also trying to coordinate with the county's outside legal firm and national counsel to ensure that we have a good understanding of any kind of risks that need to be taken into consideration for potential bankruptcies for any of the defendants in the settlement and the likelihood of future funding sources coming through. I anticipate that we'll have an update for a full update for the December 12th LGCC meeting, but that is currently ongoing right now.
Thank you. And I think the next one was on the administration also from the city for funding sustainable model or funding, sustainable models.
So I'll open up with that and then turn it over to the expert here more. I think this is really dependent on the recommendations that the body determines to move forward with on what types of funding models that would be inclusive of grants, partnerships with state and federal funds. We also have looked at in funding models that would bring in revenue to the city. That would be Medicaid reimbursement. I know that majority of the work that is underneath our HHH department, as well as we are starting to look at models both within our Albuquerque Community Safety Department and AFR to bill Medicaid for services that are currently being offered. Additionally, not only within HHH, but also any outside contract service providers, we are now going to be working with them to ensure that they are educated if they currently do not bill Medicaid for certain services, but that could be a component of the contractual agreement, as well as us providing the resources and education necessary for them to be able to begin doing so. So that would be encompassing some of those funding models and sustainability, but I don't know if I missed anything. Or...
No, it's good. You know, there's grants and state and federal allotments, and frankly, we don't have that crystal ball. Certainly now, we don't know what federal funds are going to look like for this population and safety net programs. So I wouldn't want to really speak to that. One thing we do know right now is Medicaid and ensuring that the remediations that we do choose are leveraged through Medicaid reimbursement and that type of thing. We also have to, you know, ensure that the vendors, contractors that we get in partnership that are solid and they have a good business model, and we're not paying for their staff, that they should have a business model that pays for their staff, and look into that. Yes. But conversely, we also want to make sure that there's some low bar funding, which was one of the recommendations, so we can get some of these smaller companies that have a real vested interest in the geography here and really do good work and maybe give them a leg up, but make sure that they have a pathway to sustainability over time. That's what I would add.
Dr. Lindstrom, and then we'll go to the commissioner.
All right, thank you. I would also echo a lot of what the city's perspective is on this. One of the things that we have a parallel strategic planning initiative going on to the opioid settlement plan, but also our behavioral health strategic plan. And one of the things I'm proposing there is that we have a behavioral health center of excellence where we're able to provide ongoing technical assistance to provider organizations, not only on the clinical side in terms of implementing and sustaining evidence-based practice, but also on the operations side. And how do you do sound business planning? How do you become a Medicaid provider? If you don't have sufficient scale to do that, do we potentially offer back office functions so that one can do the coding and the billing and work the denials, etc. In addition to that, we're looking at potentially moving towards an administrative services organization, not unlike what the collaborative did a number of years ago, so that we can offer an exemption through the county procurement code, and in order to form a behavioral health provider network and have provider agreements administered by the administrative services organization, and be able to have service rates that are reimbursed rather than the very laborious, administrative, burdensome invoicing process that providers have to go through now. The other thing I'd like to add is that Medicare recently expanded the behavioral health provider disciplines that they will reimburse for that had been limited to social work, but now they'll be reimbursing for counselors and marriage and family therapists, etc., which potentially
health workers.
Yes, correct. So that can also be another source that we haven't been able to tap into, particularly as the population ages, in addition. So we plan on doing similar things around Medicaid as well. And depending on what happens in the new administration, the substance abuse block grant, the mental health block grant, the opioid targeted response grants, etc., may be in jeopardy. But if they're flowing, it becomes a question: how do we better plan with the state relative to what they're doing with the opioid settlement funds, as well as the other pots of money that they have direct access to.
Mm-hmm. All right. Okay, so I think that sorry, Commissioner.
And I think Councilor people corn after me. But so yes, I was gonna just say exactly. I was gonna ask you when you say about support. I've worked in the nonprofit world for most of my life, and I know without a doubt that we do more than what city government, county government does with less, right? So and agree. I think we heard from Janice that community is demanding that we have tools to evaluate our service providers, right? So I get nervous when I hear people think like there's bad players in the community, because I think for the most part they're scrapping, and maybe there's too many of them, not enough resources. But I think there's a way that should be our responsibility, be the folks on the hill that could see the landscape and know where we can and have evaluation
and facilitate good things.
Facilitate good things for people who want to be doing good things, right? And so a provider network could embed that. I just want to ask us to always think about the collaborative piece to it, that our folks should be working together. So not because I'm worried about duplication of services, because we need more and more and more, but that way we're collaborating, meeting and creating the true system, a network, a system that works within each other. And the last part I just want to say to that I just want to, in our thinking, because I feel like the two of you are brain folks, right? In our thinking, I also, because I've heard it said a couple of times from our experts, that so when I did work at YDI as a case manager, care manager, I worked, it was before Medicaid, before they were doing Medicaid billing. It was actually I worked during the transition into Medicaid billing. And I remember that I could, without Medicaid billing, I could spend today, Stanford needs me to chill. Today, Stanford's here, he's doing fine. I could leave next week when I visit. He wants my time. And that might mean that I need to sit and play video games with him for 2 hours to where he's finally able to talk to me about what's really going on. But when Medicaid billing came into play, it was like everything needs to be billable. And so I want both. I want Medicaid billing because it's going to save us money for those things that we can bill for. But I want us to also say all those GRT funds that we get for behavioral health dollars, or all the ways the rest of that aren't Medicaid billers, that we still have the flexibility that people that are doing the practice on the ground can still decide they want to take 2 hours, even if it's not a Medicaid billable hour, but because it's what they know to do as the experts serving them.
If I might respond to that, I think one of the advantages of the Administrative Services Organization, if it's set up correctly, is that it will have pots of money, for lack of a better term, that are the safety net dollars that can fund the things that Medicaid won't pay for. Right. So those safety net services, et cetera, could be billed. There could be a rate, et cetera, for those other things that's not reimbursable through Medicaid.
If I could add to that, I was intimately familiar in the last couple of years with the Administrative Service Organization, in this case, Falling Colors for the state, being with the collaborative. And it is about the safety net dollars is run through that, the Administrative Service Organization. What it helps you do is fix your cost. They charge a percentage for all money spent through there. They don't control who you contract with, but they could put a contract together and get it out in the world in 2 weeks tops. They produce wonderful dashboards and everything like that for a flat rate percentage of money spent.
6.6% currently.
6% is the current. You're welcome. I negotiated that. No, but it's a really valuable tool. Just coming to the city and looking at some of the way we contract, having my program staff almost have to have accounting 101 to be able to review an invoice And looking at, wait a minute, that doesn't add up to 0.3 FTEs. And it's like, you should be out there technically advising, how can we get more people in your door? You know, those types of things. So we're certainly looking at that both in the city and the county.
Leave my comments next, Miss Councilor Beaverhorn.
Thank you, Madam Chair. So I'm on the conversation around like the Center of Excellence, setting up a network. I just want to represent for Councilor Grout. One of the things that she thinks is really important is for lack of a better term, like a statewide dashboard / network that really makes sure that we know at any instance what services are available, who can provide what. And I know that's larger than Bernalillo County and the city of Albuquerque and APS, but I was just speaking to her about what was important to her. And I do think that is something that we should be thinking about, whether it's us or us and other entities around the state. But we do need to set up some sort of network that could be a resource when anybody is in need to know what things are available at any given time.
Yep.
Not from me, but from Councilor Grout.
I might respond to that. Falling Colors, which operates the Administrative Services Organization for the state, just did a presentation to the Interim Legislative Health and Human Services Committee. And it was one of the features of that presentation was their dashboard. And the committee was blown away because they've been wanting, since Centennial Care was implemented in 2014, they've wanted data and want to know all these investments in the Medicaid as well as the state match. What are we buying and what are the outcomes, etc. And they were just blown away that the ASO has this capability, and they proposed to the Healthcare Authority that there be a pilot project. Take 24 data from Medicaid and let them show the kinds of results that they could report on that the MCOs don't. And so whether that comes to fruition or not, but what I guess bottom line proposing is that if you all would like to have a presentation in whatever format, you know, we could arrange for that, because I think that the thing you're thinking about, it would also kind of blow you away in terms of what the technological capabilities are with data that we already have.
It's real transparency. I mean, real transparency.
And what was the ASO stand for again?
Administrative Services Organization.
Madam Chair, if I may, so was the proposal for that to be state funded, or so I'm just trying to think through, if we want this on a state level, would that be something that the state would majority pay for, and then we might buy into that, or is it something that we would need to create?
Well, let me just say my domain of responsibility is Bernalillo County, and we're designated the authority for the county. The state's going to do what they're going to do. The reality is that whatever they do, you know, we can support or we can suggest modifications, etc. But we're seriously looking at our own administrative services organization with the same kinds of capabilities, so that at least we will have what we need relative to planning and operating, policy development, outcomes, etc. here in the county.
So just a quick question: is this the ASO dashboard? Would that be able to be utilized for opioid settlement? Like, is it a dashboard to track what the community's wanting as far as transparency of these dollars?
If it's our ASO, if the city's partners with us in this, etc., we could put the opioid settlement funds money within the ASO and use their data capabilities to produce the kind of thing we're talking about.
So you could use opioid money. You could do one-time funding awards through council or the commission. You could do CIP, capital expenses. You could run any type of money and then break it down how it was spent, when it was spent, and to who it was spent. It's amazing. It really is. And
all right, so I think that we need to that point, maybe we do need that presentation, maybe to the larger LGCC, not just I think the larger group. And then I think that would be great.
Will you let us know which LGCC meeting
let's say
et cetera,
January.
and we'll make it happen.
January, or I'm sorry, February 2020. Thank you.
February 20th.
February 20th.
Okay.
If I may just add that, you know, in working with families that have been either lost somebody or currently have someone using substances, specifically fentanyl, you know, those families have designed the Keep Enema Alive campaign, which has been a city, county, you know, they are really, it's not that they do have hopes and dreams. And I think even their name and Keep Enema Alive, they are thinking statewide. The state is obviously not in a place to be moving, and I'm glad we are in a better position, it feels like. But just to remember about the Keep Enema Alive, it's what families are saying they need to, right?
Yes.
Which is also some of that, like, see each other in other people to not feel so isolated.
Yes, that's great. Thank you. And I know they mentioned that in the compassionate messaging part of the strategic strategy, specifically they mentioned Keep Enema Alive. So I think that's great.
Yes. So this may have been covered already, but as an APS board member and 30-year veteran teacher, I've got a couple questions that you may have covered already. How will the school's APS be part of your overall strategy, and how will pediatric services be part of this strategy?
Sure. So the strategies did specifically outline, I'm just getting to the summary, prevention for a comprehensive education for youth, and also connecting disconnected youth. And so I think our purpose in making APS a voting member of this body is so that APS has a bigger say in how some of this funding gets to APS to do, or is that, I mean, that's what we need to discuss. That's why it was important that we have APS as a voting member, which we've changed. Because, and I think to Commissioner Lewis's point at our ABC board, community school board meeting and bringing it up there, we need your expertise on what we need to be doing for youth. But what the specific strategies were prevention, comprehensive education, and connecting disconnected youth. And specifically what that meant, just pulling through.
And you do have this report, right? I think I can distribute it.
I don't, but I can get access to it.
Yeah, we can share it. And then also, can I ask that the HHH gets it on our website? Because I couldn't find it on our HHH website, the actual draft report.
Sure.
I was only able to find it on Bernalillo County's.
Yeah.
If we can put it on ours also.
And so we have breakdowns for youth.
Yeah, so the breakdown for youth was promote alternatives to punitive disciplinary policies that disconnect youth from education and economic systems that are counterproductive to their growth and achievement. Support APS to offer continued engagement in school and youth tailored support services for young people exposed to drug and alcohol use through a compassionate approach. Prioritize and tailor services for system involved youth, including those in custody at youth service centers, that also ensure referrals to appropriate evidence-based services such as harm reduction, medication treatment, recovery, and family therapy. Public input really frequently touched on the need for youth-specific services, including education, outreach, and resilience building activities. And then talked a little bit about the best practices around evidence-based approach, ranging from education to early intervention, addressing risk and proactive factors in home and community, maintained for, this is a best practice from New York State Office of Addiction and Service Supports. So they had some specifics for each of those, but I think that's why we wanted APS here and to talk about what's missing, because I think that's a piece that is missing. What else? And that's what we need you all for. So I hope that answers a little bit of the.
Yeah, it does. It gives me a good general, and I'll go online to look at the report.
We'll get it online, but right now look for the county. The county has it online.
It's not on the city site.
No. It has opioid settlement information, but the draft report is not on our website.
Sorry.
That's okay. Well, we'll get that worked out. Okay. Last to do to recap was listing out I don't know, we talked about the HACC data, but the what are we already doing at each entity? So we wanted to get a breakdown from, and I know we don't have this done yet, but the premise was a breakdown from APS around what services are already, what are you already doing for this stuff now?
Okay.
Same from the county and same from the city, because then that will help us see what we're already doing that we could potentially beef up, and also see what those gaps are. What are we not doing that we should be doing? Because our general consensus was some of these 26 recommendations are already happening. If so, where? I don't think at the scale we need, clearly, but what is happening in each of our respective organizations around this, so that we can look at that. So that's so the update around that.
If I can
yes.
offer perhaps a point of clarification. There is what the city is doing, whether we talk about, the various gateway projects, et cetera, and what the county's doing, whether we're talking about the care campus or the services that we contract for. That's only a piece of what goes on in the county. So there's services that aren't contracted with us. We may not have a relationship. They're billing Medicaid, they're billing Medicare, they're billing commercial insurance. There's an independent practice association made up of private practices within this region. And there are criminal justice related grant funded programs and funded through the AOC, et cetera. So I just want to offer that if we're just thinking about what it is the county and city do respectively, that everybody understands that's just a piece of this complex system.
Correct. Yeah, I think that's I think because our purview for LGCC is counties, city, APS, that's what we're focusing on. I think that work statewide needs to happen. But I think for our respective organizations, we just need to know what we're doing. And what we have, Commissioner.
I just want to say, I would add APS and UNMH to those lists. Those are all within our house, right?
For the county.
UNM is a bulk of our contractors and is our public hospital.
That's true.
And is our public provider.
Yes.
So it's not and it's not just really city, because they're our public hospital. Right?
Yeah, I trust that you will put on your lists what you think is pertinent to this conversation.
And I guess I imagine, right, and I've tried building some of these myself, like being able to see the landscape of things. And those things like you named that we don't know, those should be in consideration, right? Like I do know a lot of those independent providers that they are ready to take, but they know how hard it is to get through and how long it is to get those county dollars to their doors. So they've just chosen to stay in private practice, not because they don't want to be, not all of them, right? But they don't all want to be serving. So I think when our system is working better, everyone else will work better.
And the inverse can be true too. You can have providers that make a point of contracting with the city and the county because it's easier than having to go through Medicaid and being contracted credentials with each of the Medicaid managed care organizations, et cetera. So,
well, I think
another dynamic.
To your point, Chris, you will put on the list what's pertinent to the conversation, even if it's peripheral to what we do.
So if I might, so for example, all the contracts that we fund through the gross receipt tax, for example, would you want a listing of all of those contracts?
And with opioids, services, addiction treat, yes.
Okay. Just
I think
I want to be clear about what you're asking for.
That for a while because people complain that we fund the same people, but it's okay if we fund the same people. Let's just see it
exactly. And see
well, we may fund the same organization. That doesn't mean we're funding the same scope of work.
Right?
Yeah, absolutely. Yeah. Commissioner Olivas.
Yeah, I wanted to jump in here on kind of like what I was hoping to see or hope we will soon see is sort of, we had this discussion last time about like we got into some specifics about like ACS was one of the things that was brought up and mobile crisis response and stuff like that. So, I mean, the whole, I'm not saying that anybody's right or wrong here, but the whole list of providers of all the people that do all behavioral health services in the county,
to me is less important than in those core areas where we outlined. So like crisis response, what is the county doing on that? I know we doubled our funding for mobile crisis teams over the time I've been here. And what is the city doing through, they've stood up ACS from 0 to like 120. So, what do those investments look like, and what else might be needed there within those existing programs that are within the framework of those 6 categories that we had sort of chosen? And I think where we were most weak speaks to my plea to really work with APS here is on the youth prevention and intervention side, because the county and the city do some of that through after school programs and the violence intervention program that the city does, stuff like that. But how do we get all that together and then link it up with APS? Because what we were talking about is how do we look at existing programs first, right? Rather than starting something totally new, going back to the drawing board. How do we invest in things that need investment, but also justify that they need investment? Right? Let's make sure we need more mobile crisis response before we say we're going to put a significant portion of that. So I'm just hoping that either you may already have some of this, or that we'll see some of that can be coordinated within the 3 entities within those 6. I think it was 6 categories.
Madam Chair, so Commissioner Lee was to answer on that. So the city has begun that work. We have been meeting with departments, specifically looking at the vital strategies, recommendations, and what the city currently does offer, what it's missing. And I think what we're hoping for that this body could do is identify the recommendations that are going to be adopted to move forward. And from there, we can tailor it to identify within those specific recommendations what we are currently doing that has an impact on the opioid crisis. And then some of which would require dollars for the opioid settlement. Some are already operational. City Council has been in lockstep with us on funding specific programs, as well as brick and mortar that we know is necessary to combat the crisis. The crisis obviously has been occurring for years. And so we have been anticipating that. So for example, with your question earlier about integration with Albuquerque Public Schools, one thing under the community or connecting disconnected youth recommendation is expansion for our school-based violence intervention program. What does that look like, and how can we bolster our efforts in what fraction of the opioid dollars can help increase the output for that? Additionally, it's thinking outside of the box and utilizing our economic development department, specifically on the disconnected youth and the age range that they're discussing. It would be partnering with APS data sharing that kids who are have a consistency for truancy or that we share information so that we have and create an environment where those disconnected youth have a place to go that would teach them life skills, job training skills. And so that would go along the prevention and connecting disconnected youth. We've already begun working with our department to say, what would this look like? What kind of impact it would have, and how much would we need to operationalize that? Lastly, really a ask would be that we've begun also internally identifying what money can be utilized now that we know would impact lives. So the city of Albuquerque has been moving forward. Again, thank you to City Council on funding some of our brick and mortar as well as program options. And I would reference some of the Gateway Center. We just opened our medical sobering unit the other day. But as we continue to see use and demand for that increase, we know that we can utilize dollars now that would provide an infusion into the system to hopefully start to see a reduction in the need, and as we continue developing the funding sustainability on this. So a little bit long-winded there, but I think that a lot of this might be dependent on what recommendations this body determines to adopt, And from there, we can funnel in and say, you know, out of recommendation for naloxone access expansion, here's what we already have, here's what we already are budgeted for on an annual basis. If we only had X percentage more, this is the population you could serve. I hope that does that answer.
So I think the top 6 priorities we talked about in the last meeting were what we were supposed to go back and look at respective to those, which were harm reduction was the number, like I think the one thing we all agreed on was the prior, like stopping deaths, prevention, treatment. I'm looking at my list. The crisis response, we had a question mark around because Commissioner Olivas' point, we wanted to see how much we're already spending there with ACS and some of the other things. So that was a question mark. The prevention for specifically the youth portion, we wanted a focus on youth. And then the education piece, I think, was not expressly called out in one of the, like as a category, but talked a lot about the comprehensive education around the prevention piece, not only just for medical and patients, but also for the youth portion. Those are the 6 that I had from our time.
And what was the prioritization of the 6?
We didn't get into prioritization yet.
No, I'm
but
saying,
we knew,
like, what was the 6?
Because we went through all of and so it would be just basically everything that's underneath that item, that title. So prevention.
Yeah, so like, but why weren't the other ones? Like, why did you get to a 6? Like, did you have to exclude?
That was the process we went through last time. So number 13 was
expanding the mobile crisis pool.
Correct. Number 19, naloxone distribution. Number 23, improve community-based treatment access and quality. Number 25, recovery housing. 27, peer support. And then we had prevention
and
as
comprehensive education.
Yeah, and the reason was because this is what we wanted to prioritize and then give percentages of funding, because some of these things don't need funding. We need a way to give low barrier funding. We don't need funding. We don't need to spend opioid dollars to do that, right? So we don't need to, so that we just based it on what are we going to actually spend money on, because some of them we don't need to, like, we can do without actually having to spend the dollars.
Okay, well, to that point, I think we still have to name them, because what I get worried about is if we don't name them, if they're not into those 6, like low barrier funding to me would be number 1 probably, because we know that 13% of all those legislative dollars don't get to the door. I'm like constantly fighting with, so I know that like Dr. Lindstrom's hopefully already working on that, right? But if we don't put it on as a priority, then it might not.
Right. And
I
don't think the idea was to exclude any of the stuff, just say these are, because all 28 of these we're not gonna, they're important, but we're not going to be able to do all 28 right now, right this second, and they're not all going to need a dollar amount tied to each of them. But I think what we can say is, here's the things that we are recommending we start with. Here's how the importance of, if we want to order them in importance or not, we can discuss that. And then we were talking about now saying we want a certain percentage of our funding to go to those categories, for instance. Commissioner Olivas, do you want to help me out?
Because so from tying these all together, so I think that with those 6 things, and thank you, Dr. Lindstrom, for actually listing out the numbers, yeah. Because we went through significant debate on how to get those, and where we should focus. And the idea here was, I kept saying it over and over, that the resources here are limited. Even though we got this big pot of money, it is really not that big of a pot of money, considering that our behavioral health tax brings in like 36 million a year.
Yeah, it's around 34 right now.
Yeah, so we're in that range, but in the scheme of our operating budgets, right, 100 million, 150 million is like 10-15% of ours, and even less on the city side. So, and this is over 20 years, so we have to pick and choose. All of this is important, but we felt that we had to pick the main things that we felt we could make an impact on. And where I wanted to go with this is to say that in order to really prioritize those effectively, because I do think we need a ranking, or rather than a ranking, I would say a percentage right? If we should be recommending to the respective bodies, city council, county commission, that 30% of this be spent on prevention and then outline what those things look like. The only way that I can think of to actually do that percentage ranking is if we know what's already out there and what are the potential needs. I don't think we can do it the other way around because then we're just kind of throwing a dart at the map and saying we think. And so I'll point to one last thing here, the example that I think, and I don't want people to freak out with the name of this, but the public safety tax that the city passed in, I think it was 2005, 2004, was set up in a very similar way. It actually had a public advisory board, just like we've been talking about with having this have sort of a public advisory board in addition to LGCC and respective appropriating entities. It had this advisory body and they went through and they ranked all these priorities. And actually a lot of them are similar priorities. Recovery housing, addiction supports. So I'm just saying, I think in my head, it should be modeled something similar on how that was set up, where there were these recommended, percentages for each category. And that was based on a need in each area, or a rough need. It doesn't have to be to the penny, but so I feel like we really need that. We really need to know in those core areas where we're at and what's needed to make an informed decision.
Thank you. Let's go to Councilor Feebleman.
Thank you, Madam Chair. I completely agree with Commissioner Levis, but I do want to say that I think one of the other things that we have to keep in mind is that these funds go to the city and they go to the county, and whatever the strategic plan ends up looking like has to go back for approval to the county commission and to the city council. And so one of the things that we were trying to balance last time is we have to come up with a proposal that can be approved by both of those bodies. And I don't agree with this, but there are things in this strategic plan that will not be approved by the majority of city council in Albuquerque. And so we have to think about that because we want this to be a success. We want this to move forward. We want to help people. And so I think by choosing the 6 or however many, I think it was 7 of those subcategories, those were things that I believe that we can get, universal support on. I think we all agree that we want to stop addiction for children by intervening in schools and doing whatever the experts at the table tell us we need to do to make sure that we are serving children. We want to make sure that we are providing addiction recovery services, transitional housing, those types of services. And so my suggestion, much in line with what Commissioner Levis is saying, is I think this body and the 2 bodies that are actually receiving the funds, we need to have a big picture view of this. We want these funds used for these things: prevention, recovery, and here's the type of things that we think are good for each of those. Here are some things that we don't think we can get agreement on and we don't think should be included. And then we set some categories. We say whatever those percentages are, and then we let the experts take it from there. I think if we start trying to put too many details of specifically what programs are being funded, we're never, we need to get this through the bodies. We need to get the money out the door, and we need to let those experts start doing their jobs.
Yes. Madam Chair.
Yep.
So when I left here last meeting, I was super excited. Man, we honed this thing down to 7. We can get behind this. We'll set up this beautiful budget table, set up these interventions, timelines, the whole bit. So I went back to the basics.
Me too. I did the same thing.
Yeah, I didn't get there, and I'll tell you why. Here's what happened. So I went back to the basic. I went back to the national settlement, and it has Exhibit E, 10 pages of remediation uses that are not only recommended, but approved that you should do. And what I found just relatively quickly was 20 that fit inside the 7. I mean, so I would love that if we can say, you know what, these are generally the ideas of how we're going to help people today and in the future and set up some prevention strategies. But then when we really get down to how do we do peer support intervention? Well, I'm going to share something with you all real quick, just for some eye candy. This is my first attempt at doing a flow chart on PowerPoint. So it's all the same color, and that's how that goes. What, you know, I'm new to the city, and I keep hearing this Gateway and Gateway West and med sobering and housing navigation. And I thought I'd sit down and take a look at how do they work together, or how are they supposed to work together? What is the continuum, right? So the entryway at the Gateway West, that's 660 beds out there. We'll have navigation and things like that. But what I have found through the description of all, you know, the housing navigation, lead to permanent housing and so forth like that, that's all housing and navigational support. What a great opportunity in your housing navigation areas that are 90 days. Oh my goodness, intensive outpatient, that's usually 90 days too. What a great opportunity to link or provide treatment there, right? You have women's, men's, youth, and family. And you can address those needs right there with medication and provide that. Now, how do I put a dollar cost in you all to say, we can do this intervention and we may have the right vendor there doing this now, the right operator now, but we might not. We will definitely at least have to amend the contract and come up with dollars and cents, or we may have to do an RFP. So when I started drilling down, trying to provide you a work plan with a timeline and dollar amounts and so forth, it would have been make-believe, really, to come with you. So I just wanted to present this as, man, this is a system of care. There's state, city, and counties all over the country that are trying to put together brick and mortars just like we already have. We already have it.
That's what I've been saying.
We already have.
Well, and you should layer the county, and we should be working together.
Exactly.
Then we really have it.
Right.
For the youth portion, the APS way, what they're doing.
Exactly. So, you know, taking our 7 general categories and then really going through and looking at the remediation uses that are, you know, that came from the settlement agreement, we can get 20, 30 actual interventions done under the categories of those 7. And to speak to your point about the 28, right? We looked through those, and I've looked through those. I've read that thing so many times. Half of them, at least, are $0. They're really a matter of adopting as policy and practice. Of course, they should have a seat at the table. Of course, we should get them involved. Of course, we want to make sure that we're working with these populations. It's changing the culture and the environment of the government to say, yes, let's give you a seat at the table. Let's make sure that you're heard. Let's, you know, those types of things. And that's $0. That's just changing policy and practice, right?
Well, and sometimes it's $0, but then you like staff buy-in, because I think the biggest part is
culture.
And so that means if we need to do incentives, or I don't know how to get staff buy-in when we're trying to turn a ship around, but people should know how to do that. And I guess I can have my maid, Madam Chair.
Oh, go to Councilor Peoplecorn.
Okay.
And
Thank you, Madam Chair. I just want to add to that. I appreciate those comments, and I think for both of the bodies that are receiving the funds to actually be able to approve something that has those 7, right? And then says to the experts, figure out how to do those 7 in whatever format makes the most sense. I would recommend that in our strategic plan that we take to our bodies for approval, that there be a regular reporting back to us on like a 6-month basis, so that it is clear what's happening at all times. I mean, we're going to have the dashboard, we're going to have all those public things, but I think it's important that we have this kind of conversation, at least on a 6-month basis as this moves forward, so that we can continue to make sure that we are comfortable with how it's moving forward. But again, I do think it's important that we do something soon that lets the money start flowing into the community, because the community is hurting and they need these services right now.
Agreed. And then we'll go to Commissioner and then back to Mr. Kim.
Thank you. Thank you. Apologies that I was not here. I messed up on my own scheduling. And thank you for all the work you all did. Thank you for saying that, Mr. Kemp, because that's my worry. I think my hope is whether they're $0 or whether they're, I think there's some money going to be needed for everything, right? But as if we don't name, so I just want to make sure we're naming them. Maybe it's not the funding cycle, because like, honestly, these first four, I keep thinking of it as we have an opportunity to build an infrastructure. We have this $150 million-ish that we would have never had before. And so while we're all doing the things that we always do, that we should be doing, and hopefully we're always doing them a little bit better, I think of this as a time to actually build some stuff that we haven't been able to do, right? And I think of when I see like the inclusive funding, I hear you when you say funding culturally specific services, like that might not pass at a city council level, right? With the city council we have, I don't know. But in my heart, like there was big news that California is now going to let Medicaid pay for traditional type of healing stuff. New Mexico's had that forever. We have a bulk of traditional healers, curanderas, drum circles, song circles, ceremonies that could be getting that funding. Why they haven't built to scale, I don't know the answer. My assumption is that there hasn't been enough investment for them to be able to build to scale. So we just keep giving to UNM and to the big programs that can always get the money because they always have the big budgets. We're never saying, hey, that drum circle who's super successful isn't getting, it doesn't even have the ability to build an infrastructure where they could actually be available to receive patients, because we do have Medicaid funding available for those kind of services. So I'm just saying that, I'm not going to push back on what can or can't be. I really hope we don't miss the opportunity to see a bigger picture, whether we're able to fund it right now or think about it in a phase that we're building towards, whatever.
No, that's a good point. And I think there's a way that we can say, these are the things we can do now. We're not excluding this, but these are the things we also need to work on process-wise that we need to get better at, that like those
or
things.
Build a plan for.
Yeah, I agree. All right, we're going to go to Mr. Rayel, and then I think Mr. Kemp had something too. And then we're going to break for 30 minutes and come back. And when we come back, we're going to get to that. I'd like Mr. Kemp, if you can work with Garrett to get that list from the settlement so we can see that. And then we can go through, start with the 7, and then see what's in that document that we can, the list of activities that we can add, that if, because like you said, they already
it's
fit.
not inclusive. Okay.
Yeah, no, of course, but I think we can use that with this and with what you're saying, and then come up with that. But to Commissioner Olivas's point, we may not be able tonight to be able to attach funding numbers or percentages to that. So Mr. Rayel.
Thank you, Madam Chair. I would just, one is a point of clarification that would maybe lead to a recommendation. I don't believe the intent of Vital Strategies, and I could be wrong, but Julie's on here to correct me if I am wrong. An implementation strategy of our respective bodies, I am a little hesitant if we are anticipating that it is one joint implementation strategy and whether or not that would work. So I would like just one clarification that I have been under the assumption that the city of Albuquerque, once the recommendations are approved by this group and then eventually by city council, we are simultaneously then working on an implementation strategy that may complement the Bernalillo counties and incorporate utilization with and partnering with Albuquerque Public Schools. But if I want to make sure that we're all on the same page, that in terms of implementation, we would be providing a implementation proposal and plan for the group's consideration that would be specific to one, programs that already existed. Is that okay? So thank you. So if that is the case,
thank you for what?
Oh, she was just confirming.
Well, I don't know if I confirmed.
I don't confirm.
Yeah, I don't
care.
I was confirming is
sorry.
the list part, not everything.
Okay.
The list.
So are we
no.
So one implementation strategy,
Madam Chair, yes. So we, when we put these mirror resolutions together, and Commissioner Olivas and I worked together, and I know that Commissioner Barbeau was working on her side. Like the plan was that we can do more when we work together. And so I fully expect that the plan will be that we continue to work together and we have one plan that is, some of it is done by the county and some of it is done by the city, but it is one plan moving our community forward to get services to people who need it. I do not anticipate any support, at least for me, for separate plans after all the work we've done to get us to this point.
Yeah, sure. Just absolute ditto on that. I always envisioned this, and you know, this was through consultations with my colleagues, county staff, with Councilor Grout and other councilors that were involved in this passage originally. I can illustrate it from a dynamic that happened at this meeting last time where I was talking about the county's crisis response and the city reply was, what are they doing on that? We didn't know they had that. That is illustrative of the whole reason that I think we wanted to do this was to solve problems like that. And I heard the mayor speak to this last week when I was at the Sobering Center and the opening of that. And he talked about how there's this gap analysis. And you know, I don't think we did this in a coordinated way, but the way that he said this is he said the city decided that we would step up and we would take the Sobering Center. We would take on that dimension of need while the county does things like, for example, the detox portion. And we also do—
Or the county contributes to some of those gateway projects.
We also contribute to
yes.
those projects, right? So there's, and he mentioned that, absolutely. And so, you know, my thinking was this is a way to bring us closer together. And it doesn't necessarily mean that we're going to jointly fund things or, you know, that kind of thing. But going through this list and then figure out what is the most efficient way to divide and conquer that list, right? Who does
and
what?
not duplicate it.
Connecting. So, Madam Chair, so still, we need one plan for our community that moves our community forward on harm reduction because they're caused by opioids. And I really don't want to see two plans for our community. That makes no sense. We need one plan that encompasses what the county can do, what the city can do, and what APS can do. And then we work together to implement that one plan.
Madam Chair, may I respond? I may have misphrased that. What I'm trying to get clarification on is timing and sense of urgency. So as the city of Albuquerque develops plans based off of whatever recommendations are adopted, I don't know what the county's ability for implementation and timeline is. And so what I am saying is that we not that we are not going to be working in concert and also looking at each other's plan so if it's a comprehensive one plan, my concern is that also that we identify and prioritize based off of what is currently in process and available to begin utilizing dollars that we know would be impacting for saving lives, for prevention purposes, for harm reduction purposes. And so what I would hope we don't put ourselves in the situation is that we extend this process another, and I know that's not the intention, another 18 months or 6 months. And so my initial question isn't to say that we should split up. That was not my intent. So I probably misphrased that. What I'm asking is on need. If the city of Albuquerque has proposals for consideration that has an implementation strategy for 0 to 6 months that the county may not have because they may not have programmatic structure already in place that would meet one of the criteria. I just want to make sure that we're taking that into consideration. So in other words, like if we choose one of the 7 as one of the priorities, if the city's ready to go with one of them, but the county still has to do some additional work. I don't, do you see what I'm saying?
Councilor. Madam Chair, thank you. So I really have a serious problem with the premise, right? There's one plan, and if the city is ready to move on one part of that plan, then we move on that. The county doesn't have to duplicate those efforts. And maybe the county's ready to move on something before the city is. The whole point of this exercise has been that we come up with a plan for our community, and then whoever has the resources to do that part of the plan does it. But it's not, the city's not proposing anything. It's the experts at the table who are going to propose how to spend these funds, and it's going to be done in whatever method gets those services out to the community fastest. I really, it's not okay for the city to propose something and say, well, what's the county doing? No, this is one plan that we're all working from, and whatever resources are needed come whenever we can get them out the door from whatever entity gets them.
Yeah, and I think what I'm hearing, Mr. Al, is if the administration has something that fits into these things that we're adopting and they want to spend the opioid dollars on that, will our processes here hold that up?
So right. So like I said, when I misphrased it when I said separate implementation
right,
plans. What I'm meaning is timelines. If timelines don't match up. So as you're saying this, I think we are on the same page. It is that as we look at it, we know the city has things that are ready to be operationalized or are already in operation, but with a slight increase in dollars would have a wider impact. And so
like the medical sobering, we're only opening with 10 beds.
Correct.
If we had some of this funding, could we get to 50 faster?
Right. Exactly.
If it's in the plan.
So right, so if it's in the plan, well, but if it's part of the overall recommendation that's adopted, it's mainly on implementation priority. So like if the city's able to say, hey, we can move within 0 to 6 months on this. I want to make sure that we're not hindering each other on what
sure. Commissioner Barboa, Olivas, and then Mr. Kemp.
Yeah, just to say, like, I think we have to have a plan. Like, and I said this when we first got it too, right? Like, these are literally off the backs of dead people and their families. And I hope we get to the place where we're talking about what's missing, because like families are missing in this structure that we've been talking about. And so that's what worries me. Is that like I understand it. And when we first even paused the dollars, people were like, everybody knows we need treatment. I know it too. And yeah, my family's suffering without treatment. But there's also just like, we have to have a plan that's gonna work for all of us and that doesn't. So I think as long as it's in the plan, when the plan's done and approved and then the city wants to move, I wouldn't imagine that there would be a reason that we'd be like, well, wait, we haven't started ours yet or something.
Commissioner Lucas?
So I'm a little frustrated on the way this is headed, because I believe, to Madam Chair's great credit, there was a tremendous sense of urgency placed on this effort at our last meeting. And the expectation was that both sides would come to the table with those specifics on items 1 through 7. I'm really sorry. I love this map, but this is not what we asked for. This is really important, and but I can think of so many ways this ties back into the numbers that were read off here earlier. And so we're being told on one hand that there's a great sense of urgency and that we're somehow holding this up. When I was prepared to come in here and see a presentation that took us through, here are 3 core areas in crisis response that we need help now. Here are 5 core areas in youth prevention that we think are really critical and we could move on quickly. But what I'm kind of starting to hear here is, can you just approve this with some very broad categories and trust us, we'll take care of the rest? And that is not what I intended this to be when I co-authored this with some very well-meaning people. With all due respect, again, this is important, this is foundational, but if the urgency is the goal, and I think it is, I know that Madam Chair communicated that last time, then the way to do urgency would be to come here with specifics. And if there are supposedly things that are already ready to go, then why are we not hearing about them?
Mr. Kemp?
Thank you, Madam Chair. I agree 100%. The reason why I presented this is to understand, and we can look at those 20 identified remediations that we could actually implement. from 1 week to 7 months, you know, it's a timeline. What I wasn't prepared to do, and I apologize, is to put a dollar amount to these interventions. What this shows is when we do get down to the nuts and bolts and actually get approval to submit a plan like that in coordination with APS and the county, is where all these things are going to happen. When I look at peer support, every little blue square should have that, right? I can't put a dollar amount on that, and I can't give you a timeline on that. But every a community access to medicated assisted treatment, at least half of these could have access to that. I already have a provider, ready to go. Okay. So those 7 categories need to be drilled down and proposed in a way that you say, yeah, what I can't do right now, or what we can't do right now is give you a dollar amount for the peer support program. What we can do is say, these 7 blown up into micro detail of what we can get done, how many people could get served, and what kind of timeline we're looking at to really make a difference in opioid deaths and people in long-term recovery. So
I don't think we need a dollar amount. I think our goal is to do percentages of the bigger picture of how much we want to say each respective body of this pot of money can spend on prevention, on this and that, not getting to the granular, how much is it going to cost yet. Sure. So I think just in the interest of time, we're going to go to Dr. Lindstrom, and then we're going to break for dinner so that we can come back ready to get to Dr. Lindstrom's list and
we don't have to go all through this before we break, but I did want you to have it as a reference point so that if we need to, we can discuss it in greater detail. I came away from our last meeting that my counterpart here, Stanford, and myself, we're going to present you with a work plan on what we thought would make the most sense with the limited amount of dollars that we have, and that the strategic plan covers the next 3 years, and what would make the most sense to recommend to you all in each of the priority categories that you outlined at the last meeting. So for brevity's sake, let me just focus on the mobile crisis team objective, which was one of the priorities selected at the last meeting. The reality is that we have roughly 7 different types of mobile crisis team response for adults, both on the city and county side. Some are the sheriff's deputy with an EMS, or likewise with APD. Others are with a law enforcement officer and a clinician. ACS is all civilian. And so where we have the big hole is, what about mobile crisis response for youth? And we also said as a priority is that, you know, kids have needs and that we should address them as well. Well, given my own background, Stanford's as well at the state, I know that CYFD decided to adopt what's called the MRSS model, which stands for Mobile Response and Stabilization Service, and worked with Medicaid to provide a mechanism for Medicaid to pay for this service. And without going into the details about how this service is different from adult mobile crisis, is that one, these teams would be have expertise in child and youth development, so that they don't treat young people as little adults, if you will. The other piece is that a member of this 2-person team can stay in the life of that child or family for up to 56 days after the crisis to assure that there is ongoing stabilization. That's just not, you know, they meet a kid, you know, in whatever natural environment that child happens to be, is in a crisis. Maybe they're, you know, they've overdosed, they're detoxed, you know, they're got PTSD, whatever the case may be, that it's not just a one and done kind of intervention, that it can follow this child and this family, whatever the living unit is, to assure that there's enough wraparound services, et cetera, to mitigate a reoccurrence of what caused the initial crisis in the first place. Now, CYFD endorsed this, rolled this all out, provided the leadership, worked with what was then HSD, now the Healthcare Authority, to get Medicaid to do all of their rulemaking to support this service. When I talked to Rodney McNeese at UNMH, he informed me that they've been one of the provider organizations that was planning on standing up the service. And I said, well, why haven't you? And he said, well, CYFD told us they don't have any trainers for this model, and you can't implement it if you don't have a trainer. And my response was, I know other states that have implemented this model to fidelity, and there are trainers in those states. So if I need to pay to import a trainer from, you know, Vermont or from Ohio or from New Jersey, we'll do it, and we'll get them trained so that we can go ahead with implementation. Allface is another provider organization that planned on implementing MRSS and hasn't been able to. In further researching this with former colleagues in state government, I've been informed that CYFD basically has walked away from this program. That doesn't mean, in my book, that we have to walk away from it.
And that's something to talk to the state legislature in the session about.
But the reality is it's built into Medicaid. So the reality is if we put up the implementation dollars for both, for Allface, the UNMH, we can stand up in order to have 24/7, 365 coverage of any mobile team. You need to have 4.3 teams. So let's, in year one, stand up one of these teams, and then years 2 and 3, stand up the balance, if you will. And so I projected, based on some other states' cost data, what it potentially would cost us. And I don't think it would cost us as much, because once we got up to sufficient utilization, Medicaid would be carrying the largest freight, and then we could use our dollars for the things that Medicaid isn't paying for. So that's just one example of something that I think really makes sense, and this particular priority that you all have identified. And so after we break, we can go through some of the others.
Great. Thank you, Dr. Lindstrom.
Thank you.